I now invite Dr. Sunita Chaurasia for her talk on surgical management of acute hydrops. She needs no introduction. She is the master in the field of endothelial keratoplasty as well as lamellar keratoplasty, and she is a brilliant surgeon at the LV Prasad Eye Institute, Hyderabad.
Yeah, thanks, Purvasha, for the kind introduction, and thank you all for being in the session with us. So, I'll be dwelling upon this topic of surgical management of hydrops, indication, principles, techniques, and the outcomes with various management. So, Purvasha and Prabhakar have nicely covered the respective talks, and I'll be talking on the surgical management. We all know, and Purvasha highlighted how the hydrops occurs, and basically this is because of a sudden split in the Descemet's membrane at the Duas layer, leading to a stromal edema, and the extent of the edema depends upon the size of the defect. This complication can be seen in advanced keratoconus and other ectasis, and as Madam pointed out, it can also occur in certain other conditions which are involving thin cornea where there may be a collagen abnormality, not always seen in keratoconus and pellucid, but there are many other entities where we don't understand the pathogenesis, and it can also occur as a complication of a trauma in the eye in so-called normal subjects where we see hydrops. Now, traditionally, we have been managing these cases with a desmetopexy with tamponading gases, and these have been long-acting gases such as C3F8 and SF6. This is based upon the principle to oppose the posterior membrane by pushing it to the anterior corneal layers. Technically, this would not be a very ideal procedure in biomechanically weak corneas because you're trying to oppose a weaker tissue and trying to push the posterior membrane against a weaker tissue. And this, apart from that, this also has several problems such as risk of cataracts, Urizavella syndrome, pupillary block in young phakic eyes, and these would also be inadequate in inferior defects because obviously when the patient is upright, it does not work that way. And this is just to show one case where there was a pupillary block with C3F8. Now, why do we need to treat these cases? Simply because many of these long-standing hydrops can result in neovascularization of the cornea, especially if they're large ones. So that is the whole reason why surgical intervention would be required. Another way of management of these cases is by applying full thickness sutures, compression sutures with tamponading gases, and this is based upon the principle of bringing the edges of the split Descemet's membrane together. So this is in this technique, in many of the techniques, it is to pass the sutures through and through the cornea so that you are able to oppose the Descemet's membrane. Some of the techniques also involve venting of the anterior surface so as to remove the fluid which is there in the stroma. So I'll be just presenting few conditions where we have done a little modified approach to the compression sutures and how this has avoided the certain issues which used to happen with the earlier methods of management of hydrops. And I'll be discussing in three situations, namely keratoconus, pellucid, and a case of trauma. Now, this is the first representative case of a keratoconus. This was a patient who had non-resolving hydrops of 3 weeks duration and was also developing vessels in the temporal cornea. Though initially he was in medical management, it was not resolving and leading to complications such as vascularization. So the procedure just simply involves making a side port to inject air bubble. It is not tamponading gases, it's just air bubble to delineate the level of the posterior membrane. This is important to understand where is the posterior membrane so that the sutures where you're passing, you have an idea about it. And these sutures are partial thickness. They are not full thickness through and through. They are just partial thickness within the stroma to create a compression or an indentation effect on the surface. And the air bubble provides a kind of guidance to what level we are. And once you do that, we can see that there's a significant amount of edema resolution which happens while passing sutures itself because the sutures act as venting also of the fluid. And then when you compress, when you provide the compression sutures, the edema in the periphery is seen to resolve first. So this is the post-op day 1 picture. This patient had limited cooperation on day 1, and then we got the pictures done on day 3. We can see a remarkable improvement in the corneal edema. So a similar case of pellucid marginal corneal degeneration. So similar technique. Now in pellucid, the break happens to be crescentric to the limbus, and usually it is either inferior or superior. So here again we make a side port, put a small little amount of air bubble, and the sutures are taken radial to the crescentric breach, which is in this case at the inferior location. The small amount of air bubble is simply taken to just push the Descemet's membrane opposing to the anterior corneal layers. And this should not be occupying the anterior chamber too much, because there's a risk of pupillary block even with a small amount of air. So it should be less than 20 to 30% of the anterior chamber volume. So this is a post-op day one of picture of the same patient. And this is the third patient I'll be discussing about, a case of post-trauma. This was a very unique case where the child had a thin cornea in the opposite eye as well. It was not really ectasia, but then this patient had an overall thin cornea, and he had an injury with a ball. Not a very significant impact as per the parents and the boys recall, but this is how the picture looked like. So if you can see the picture, it looks like complete edema in the cornea, and the OCT is substantiated by the fact that there's a breach in the posterior membrane, and the area of the translucency corresponds to the site of the breach. So there's a circumferential 360 degrees breach, which is leading to accumulation of fluid within the stroma. Now, how did we manage this? This patient, again, similar technique was done, side port with an air injection to delineate the level of the breach, and partial thickness sutures have been taken in this case. In this case, we had to take circumferential sutures because the breach is all throughout in the mid-peripheral part of the cornea. And these sutures have to be a little tighter, and they have to create a compression effect so that the posterior defect comes closer to one another. So it almost looks like near keratoplasty, but this is what was required simply because the breach was quite extensive, and this was followed by a BCL application. Now this is the day one picture of this patient. There was a dramatic resolution on the day one because we have addressed the cause. One is by the compression, we've removed the fluid in the stroma, and the second thing is bringing the edges of the tear closer with a little amount of air bubble, which was seen on the first day. And this is at 1 week where when the child's visual acuity was restored. So what are the advantages of the modified step? So one of the modification step is taking partial thickness sutures. Now this makes suturing of the grossly edematous hydrops cornea way easier. Unlike if you want to take the sutures through and through, it is very, very difficult to locate because of the significant edema there. But if you're partial thickness, your suturing is way, way easier. No special needle is required. The sutures serve the role of venting incision also by draining the fluid, and the resolution of the edema, as we saw in the first picture and other video also, happens to be seen intraoperatively as well. Air bubble is used. Air bubble means 100% air is used, and there's no C3F8 or SF6. And bubble size should be less than 30% of the anterior chamber volume. So this eliminates the risk of pupillary block and SF6 and C3F8 gas-related complication, which can occur in the long term, such as cataract, Urezevelia syndrome, and many others, which can occur because of air bubble in the anterior chamber. The technique is also not dependent upon the gas in the anterior chamber, so it is effective in inferior breaks as well, and can be applied to diverse indications such as keratoconus, pellucid, and trauma-related hydrops. Now, what are the suturing strategies and patterns? The guiding principle for the suturing should be perpendicular to the tear when you can identify the tear. In quite often, in many cases, many situations where the edema is profuse, we can't make out where the breach is. It's really hard to know where the tear is. So if we can locate it, the guiding principle should be, the caveat should be to have the sutures perpendicular to the tear, as is shown in the first picture. If we are not able to see it, in a case like keratoconus, because these tend to happen in the central part of the cornea, the suturing pattern could be arcuate. It could be circumferential from limbus, starting from the periphery to the center. And in the center, because we want to avoid the sutures passing through the stroma, this could be infinity sutures, where the sutures in the center are more like overlay. They don't pass through the stroma. They are on the surface of the cornea. So it could be an infinity suture. And these are the various patterns which can be attempted in various types of hydrops, which you can see in situations where there could be multiple loculi, or it could be related to the location. We can make use of these patterns to provide the compression effect. In pellucid, because the tear of almost always is crescentric to the limbus, should be in the radial fashion as is shown in the figure 6. One of the ways of identifying the posterior tear could be by using an endoilluminator or a light pipe. This also delineates in some cases the breach and where it is located. Now let's go into what is the mechanism of quick resolution. The resolution happens on the way the edema resolves is based upon the concept similar to a buccal surgery for retinal detachment, where when we provide external tamponade, there's an apposition effect. So similarly with the compression sutures, what we are creating, if you can see the cartoon, The effect of compression sutures is to bring the biomechanically weak cornea closer to the posterior defect and thereby facilitating the natural process of edema resolution, which happens um, as a natural mechanism. What is the post-op regimen? Post-op, the patient still has to be using hypertonic saline until the time the edema has substantially disappeared. Antibiotic is required because we need a BCL in place. We'll be putting sutures, and sometimes when the cornea is very thin, we may not be able to bury the sutures. So putting a BCL helps in many ways. It makes the patient comfortable, and if any point we've not been able to bury the sutures, it also gives a symptomatic relief to the patient. IOP lowering agents can be used in very thin corneas. Steroids have to be given to suppress the inflammation because any fluid in the cornea is an immunogenic cause. So steroids have to be given to improve the comfort, and patients should be instructed to avoid rubbing the eyes, because certain times if they rub their eyes, the sutures can have a gaping with the thin cornea. So that instruction should be a part of management in Hydrops when you are managing pediatric patients. Follow-up review and suture management. Suture removal should be done when the suture loosening is noted, and it should not be prematurely removed. The cornea, the posterior membrane should look sufficiently healed well. Because if we remove the sutures prematurely, again the defect, because of weakening, inherent weakening, you can again have a gaping, and edema can kind of reappear, so resurface. So it is important to remove the sutures only when we feel the healing has been sufficient. However, not to delay it to very advanced stages also, otherwise you end up having scarring. So you have to just have a balance of this time point of removing the sutures based upon the healing of the posterior membrane. So this is the outcome of 25 cases which was managed with this modified technique. Most of these cases which were managed were cases where the edema was grade 3, which means that it was larger than a circle of 5 millimeters diameter. 14 cases were keratoconus, 5 were pellucid, and 1 was a thin cornea, as what was described in the third case. Recovery of the edema from pre-op to the day 1 was 90% on day 1, 95 to 99% by 1 week. Edema may resolve, but then the healing is the point where we have to remove the sutures. The pachymetry from the initial baseline unrecordable came down to 714 microns on day 1 to 593 microns by 1 week. And the mean time interval complete removal of sutures was 50 days. This is taking into account pellucid also, where we did not remove sutures in many of these patients because it was giving a kind of improvement in the refractive stability also. 10 patients were managed with the glasses in the series. One patient required a peaky keratoplasty. Rest were managed with contact lenses. And in 3, visual acuity could not be assessed because these were patients of Down syndrome, and much visual assessment and rehabilitation could not be really attempted in those patients. So mean follow-up has ranged from 2 months to 24 months in these patients with an average of 11 months. So do we need compression sutures in all cases? Do we need to manage all patients surgically? We don't have to, but this is one algorithm which could be used for management of acute hydrops depending upon the cause. So if we have we can determine what the cause of the hydrops is. For pellucid, because the tear is in the periphery and cornea is relatively very weak, these patients should go for compression sutures radially. With keratoconus, one has to look at the size of the hydrops. Size of the hydrops, if it is like grade 1 to grade 2, which means less than 5 millimeters, one can simply go for conservative management. These need not be managed with compression sutures. We need not do anything because resolution happens far quicker in smaller size hydrops with a 1 to 2 weeks time. So these cases need intervention. However, there's a possibility that when they may begin with a smaller defect and the patient, when they rub their eyes, the edema can increase, the size of the defect can increase. So initial management could be conservative for such patients where the size of the hydrops is smaller. But if we see no resolution or increase in the hydrops at 1 to 2 weeks of follow-up, these patients will be subjected to compression sutures. Grade 3, more than 5 millimeters diameter, it is better to plan compression sutures for a quicker recovery because, as we already have seen from basic literature and also we see in clinical observation, long-standing hydrops can result in neovascularization. So for a quick recovery, it is important to plan a surgical intervention in these eyes. So I'll be just showing a few more cases which I had, and this was a case again of a large hydrops, and this patient actually came much later. So if the hydrops has been there, such a voluminous hydrops, if it has been there for a very long time, it also leads to fibrosis. So it was really difficult to actually bring the cornea into apposition because fibrosis is sort of set in. So we don't have the side view profile, but the cornea was almost like a mound in this patient, and the patient was extremely symptomatic, and this was something had to be done for this patient. So we can see how we are starting from the periphery to the center. So in between, what is going to happen is that we may have to take repeated sutures, because once you start taking sutures, one suture may become loose and one suture may become overtly loose. So and then it serves no purpose, because the fluid tends to drain out at the time of surgery itself. So you may have to replan some of the sutures, remove them. So it may sometimes be a little time consuming for an hydrops of this nature. So you take one suture and the other becomes loose, and you may again have to go and for taking suture at another location. This would be a part of the surgery itself. But when we keep doing the procedure, we start seeing how much difference it starts happening right at the time of the surgery. So you can see how it began with and how the edema is gradually resolving intraoperatively. So we can see the remarkable resolution, and then thereafter the patient becomes very comfortable when you manage these cases surgically. So one more case, and this one case where it was not responding because there are multiple loculi, though the area looks smaller, but then this patient was taking a lot of time because there were multiple defects in the central part of the cornea. So this could be seen with the light pipe very easily, and again subsequently an infinity sutures was taken. The sutures are passed through the stromal part of the cornea in the periphery, and they are like overlay in the center part. So you don't actually pass through the stroma in the center part, in the central visual axis, to minimize the scarring which can occur as a consequence. And then once the edema resolves and we are happy with the posterior membrane healing, we will remove these sutures early. And again, we can see remarkable resolution right on the table itself. All right. So that's all I had, and Purvasha had some cases to share, and if there are any questions, we can discuss.
I'm not a cornea person, I'm a cataract person, but this was a very interesting presentation. And my question would be that can you use these same techniques for non-resolving post-operative bullous keratopathies?
No, actually, because there the mechanism is different. Post-op, if you're saying like the Descemet's
Yeah,
membrane
that
detachment, they are simply once you just inject air
no,
bubble and you'll have a.
suppose like it has settled in, like and even after some repeated gas injections or something, there's a lot of residual bullous keratopathies there in the cornea. Can we you do these procedures, or has these procedures been tried?
Personally, I'll not recommend. I won't favor that. I'll only prefer to just do a desmetopexy with air bubble, because there the anterior part of the cornea is normal. Why we are doing this procedure in these patients is because the anterior part of the cornea is biomechanically not normal. So just pushing it
Right.
against with the air bubble, it does not logically make sense for these cases with the SF6 and C3F8. Whereas there, when the cornea is normal post cataract surgery, the stroma is normal. So you just have to simply, and that is just purely Descemet's membrane. Here it is Descemet's membrane. Majority of the times it will be Descemet's membrane along with the Dua's layer, which is little different. So and that which is going to be a little taut also. So here we have to create a compression effect rather than some pushing effect with the
Right. And
gases.
my second question would be, I saw your post-op regime, and you have asked for hypertonic saline. Have you tried ripasudil, and what is your if you have, what do you feel, does ripasudil have a role in corneal edema?
Yeah. So Ripasudil, I'll prefer to use only in those cases which are little. I have used in a few cases. However, I've not analyzed the effect of it. Like to know whether what is working, you'll have to have a large series, and it is really hard to know that. Ripasudil can also cause vascularization in the periphery. So when there is a lot of peripheral vascularization already there, I'll not use in those cases because it tends to favor increase the vessels. But if it is just localized to the central part of the cornea, I have given in few eyes. Whether it makes a difference or not, because it's really hard to say at this point in time. But
Thank
yes,
you.
interesting observation and interesting question to look at.
Thank you.
And also to add to your query, to the answer that ma'am has given, Merin ma'am, The basic pathology behind the pseudophakic bullous keratopathy is the dysfunctional endothelium also. So, even after repeated desmetopexies, if the endothelium has stopped working, here it works because the endothelial layer then takes over, migrates, enlarges, and then migrates and covers the defect. Whereas in bullous keratopathy, I doubt if it's functional enough to take over the endothelial pump function again.
So, ma'am, you mentioned that the main indication for you for doing compression sutures is to prevent vascularization. In terms of long-term scar formation post-resolution, do you see a difference between patients that have undergone compression sutures versus patients that have undergone conservative management?
I think that when you just leave it for just resolving on their own with a natural mechanism for large hydrops, it takes a really long time, and sometimes the scarring is way more. The whole reason for intervening is to have a quicker recovery. Because the patient sometimes is symptomatic, and then if you just keep waiting for 3 to 6 months, cornea in some case actually it gets fiery red. Like we have seen all that happening, and that is why if we can do a modality where you can have a quick recovery, so that is why we have to follow a certain algorithm, because not to generalize like every case requires compression sutures. If it's a small central area which will just subside with natural mechanism, yes, we should target that. But if it is not, and if it's taking a lot of time, we have to. Regarding the point about scarring can occur, because but one of the ways strategies is to apply the sutures are like an overlay, not to pass it through the stroma. So that ways you can minimize the scarring and not to keep it for a too longer time, because when the central cornea has healed well, then usually within 1 month, in case of keratoconus I'm talking about, and majority of them will be little younger patients, they heal quicker. Okay, so those kind of cases, like I don't see there's a lot of scarring in terms of whether you had left them alone versus when you manage them. So from the historical data, I'll say the scarring is sort of inevitable in quite a lot of them, but in some cases, because the edema resolves faster, the scarring, though because it will occur as a consequence of the breach that happens, but they can be rehabilitated. Majority were able to be managed with glasses or contact lenses. One case required a PK because it was a long standing, and that was a scar was right in the center, and that so one case we had to do a PK, but that would anyway be required for even if you manage the hydrops conservatively.
Ma'am, I have a question. Do you combine always I mean, compression sutures along with air injection into the anterior chamber, or it's is it like you always combine that?
So air bubble, I feel it is important as a part of the procedure, because when you see through the operating microscope, you're not able to judge where your Descemet's membrane plane is.
Right.
But when you inject a little bit of an air bubble, it is more to facilitate your passing the sutures at what level. Because you're not going deep, you don't want to, and it's more like when you have the air bubble, you know what depth you are going. So it's mainly for that purpose. It serves as a guiding tool for understanding
Yeah,
the
because
level
by
of
the
the
end I
sutures.
saw that in all of your procedures, the size of the bubble was much smaller
Yeah, I
than
have
usual.
removed them intentionally,
Yeah,
because even air bubble I would not want to keep if I can, but I just like to keep a little very minimal amount of air bubble, because it just gives a little tamponade. And if patients are not on the GA, I will also ask them to just be supine for with a small amount of air bubble, because it just helps in whatever micro leaks may be happening,
right,
that helps
right.
in settling down quicker. So that is also one of the reasons why you see a dramatic recovery probably in these cases. Not having a very large air bubble, but a very tiny one just for a few localizing the area where you see the defect.
Can I add a point to that, Dr.
Yeah, yeah.
Sunita? I think she's mentioned it in her paper as well, that one of the biggest advantages of this procedure is to avoid the complications of air and gas injections. I think she
Right, right.
discussed that in the paper. But that said, like she rightly said, when you have a medium or a larger size air bubble at the time of the procedure, which you will remove later, one is to know the depth, because the cornea is so edematous, you don't
Yeah,
know, how deep your sutures are going. And I also feel that it benefits in the fluid egress that happens
True.
on table. So the sutures themselves form a wick, and they dehydrate the cornea. That effect is enhanced when there is a bubble of air. So the two-way benefit is there, and then the air can be removed in the end.
Yeah, yeah, very important point, because it also prevents the continuous migration of the fluid while even when you're passing the sutures. So
And
very right.
also, to add to that point, ma'am, where primary suturing helps, could it be that we can compare it with the analogy of skin suturing? Suppose where we perform the primary wound closure and we allow the healing to take place at a much faster pace than allowing the secondary suturing and secondary wound healing to take place, where a lot of inflammatory mediators and all those are, and the healing mechanism has to take place just to fill up that much of a defect which is now gaping. So I think primary suturing or primary compression sutures that way help the body in the healing process.
Yeah.
Scarring is less.
Yeah. So see, if you just think about how the natural healing is happening, it is by the migration of the endothelial cells.
Exactly.
So when you are actually compressing it, you're actually bringing the edges of the tear in a way far closer and quicker. So that natural process also happens quicker. And if the size of the defect is like can be with your compression can be brought way closer, you automatically achieve that effect right at the time of surgery. So in a way, by multiple mechanisms, it gives you the advantage.